All right, good morning. I'm Ray McMahan. Just to give you a little bit more information about Prime Therapeutics, where I work for, we are a privately owned company by 13 Blue Cross Blue Shield plans, so some of you are here today. We're owned by Florida, Alabama, Minnesota, North Dakota, Kansas, Oklahoma, North Carolina, Texas, Illinois, New Mexico, Wyoming, Nebraska, and Montana. We have partnerships with 5 additional Blues plans, and so I work very closely with the presidents of each of those plans, their pharmacy directors of each of those plans, and managing specialty medication. So I will get right into it here. So does anybody know what this is? This is the first cell phone, or from what I can see is a picture of the first cell phone. So did anybody have one of these? Wow, a few of you out there. That's pretty good. So what was the cost? Any takers? So what I could see is that it was $4,000 for this. And so what I had found about this phone is that the first cell phone was invented in 1956. They made improvements from that. So between 1965 and 1980 is when cell phones started being purchased. So I believe that's probably this model here. So $4,000, unbelievable. So $4,000 back in that time frame was a lot more than $4,000 today. And so here we have present day. I think the 5S or the 5C is coming out tomorrow. How many of you are getting the new iPhone tomorrow? And so the cost of the new iPhone, I hear that the cost is $99 with a plan set up. So extreme difference in cost, but much more technology that were offered in our cell phones compared to what we had long, long ago. So less price, more to offer. Very different from what we have for drugs today. And so how many from your cell phones, how many feel that you could live life without your cell phone today? A couple. Probably have a better life without your cell phone today. So I'm going to just wanted to kind of level set everybody and get your minds thinking about the specialty patient. And so some of you probably have been a specialty patient before. I myself have been. I was diagnosed with cancer when I was 17. I had Hodgkin's disease and obviously got through that, but had all the side effects, lost all my hair, gained tons of weight. But just thinking about that specialty patient overall, either you or someone that you've known, and when they're diagnosed with a specialty disease, and we've talked a lot yesterday and today about chronic diseases and the fact that they're preventable, and some of these specialty medications are not preventable. So when you think about multiple sclerosis, rheumatoid arthritis, you're given that diagnosis, and you not only have a change in life because of that diagnosis, but you have a change in life because of the cost of that medication. So think about getting the diagnosis at the doctor's office, then going to the counter to pick up your medication, and you find out you have a $200 copay for something you had never had to take before. That's a huge impact for a lot of families today. And then when you think about telling your family that you now have this big impact, it's a life changer not only for you financially, but a life changer for your family. Because now I have this $200 expense or whatever it might be, and that's for the rest of my life. So tremendous impacts, so we have a lot of room to grow in managing specialty medication. So again, I won't touch on all of these. I actually took some of my slides out because we went through a lot of this yesterday. But chronic diseases are non-communicable illnesses, prolonged in duration, do not resolve spontaneously, and are rarely cured completely. So you'll see some of the chronic diseases, and much of those we did talk about yesterday. But to point out, cancer and arthritis, those are 2 disease states in the top chronic diseases that have specialty medications that treat them. So significant cost in those areas. And we talked about these, and I think the big one to hit on there is, again, those chronic diseases are generally preventable. And to the difference of these, that generally these disease states are not preventable. They're generally hereditary or genetic in nature, with the exception of HIV, of course. So a lot of these, you're not doing something in your life to get them. You just automatically get them. So it's not something you're planning for. It's not something you can alter within your lifestyle. You're getting these. So I wanted to just talk about specialty drugs in general to give you an idea of what they are. So they're very complex drugs. When I think about specialty drugs, they're drugs that are made from something in the environment. So there's a number of drugs that are actually made from hamster ovary cells. So find that hard to believe, hamster ovary cells. Some of the drugs are actually made from human blood, and then it's manufactured multiple times to get a medication they call IVIG. They're covered under both benefits. So the specialty drugs are covered under the medical benefit as well as the pharmacy benefit. They can be, I'll go over to this side here on the how. The new specialty drugs are starting to be administered by mouth. So there's some in the multiple sclerosis class as well as oncology that are administered by mouth. Most of the specialty drugs, though, are injected, infused, and then inhaled. So you can get the drugs at home, an infusion center, doctor's office, or a hospital, and then they're either self-administered by you or administered by a healthcare professional. And just a couple things I wanted to say in addition to these. A lot of the specialty drugs have what's called their limited distribution drugs, meaning that these drugs you can't just get at every single pharmacy. You have to get them at a specialty pharmacy, and this is where the drug manufacturer and or the FDA has mandated that these drugs only go through a small subset. So it might go through one specialty pharmacy, it might go through 5, it might go through 10. And that's really because of the rigor around managing these drugs with the patients, because of the harsh side effect profile, or ensuring that the members have had tests already in place. So the member might need to have a pregnancy test, a liver function test already in place, and or ensuring that the doctor is trained to be able to prescribe and give this medication to the patient. So that's a limited distribution drug, which is a subset of specialty drugs. There's significant cost, and we talked a little bit in the last presentation about some of the behavioral health issues costing around $17,000 per year. So just to put that into perspective from a specialty drug, the traditional drugs cost about, on average, $60 a month. Specialty medication, on average, is about $3,000 per month. But that really can go up to certain patients that are hemophilia patients can go up into the millions, where you have $9, $10 million per year for some of these therapies. So in the work that I do, I get these questions, and I work again with the plans and also with a number of employer groups who are contracted or they get their medical insurance through those blue plans. And the question is that, why am I spending so much on specialty drugs? What can I do about it? Because there's always concern with, if I'm restricting some of these high-cost drugs that the patients need, am I going to be on the front page of the Wall Street Journal? We call that the Wall Street Journal effect. We don't want that. Am I seeing the whole picture from a cost perspective? And what can you, how can you help me manage my cost? And then how can you help my members? And that's the big thing. Prime Therapeutics is not run or managed by Wall Street because we are privately held. The Blues plans as well. So that's a huge focus on them. How can you help my members with their disease, with getting access to their drug, and also from a cost perspective as well? So the impact of specialty drugs. You can see that specialty drugs, or actually I'll go here to the traditional drugs, lots of volume. So these are generally those drugs that are talking about or helping with the chronic diseases that we talked about yesterday. So large volume, small cost. You'll see the specialty drugs here. Low volume, high cost. So it's a smaller subset of patients, but much more of a large spend to manage. So specialty drugs, and I touched on this with the price, but specialty drugs are 50 times more expensive than traditional medication. And in 2018, they're going to be 50% of the overall drug spend. So when you think about managing drug spend within your states, 2018, it will be 50%. So again, back to the low volume, but a huge amount of spend that you'll have to manage. A lot of people ask, so what's driving this specialty spend? And why are we seeing it increase at such a fast rate? So we see around 18% increase year over year. And a lot of that has to do with increased use of these drugs. So there's a number of drugs on the market, and they're still in studies, and so they might be, they might have an indication for rheumatoid arthritis today. They'll get a new indication for Crohn's disease tomorrow. There might be a medication that's out that has an indication for a disease that there was no drug before. So a lot of increase in use is driving that, and identification of patients that were not aware that they had this disease in the past. So hepatitis C is a big area where they didn't realize they had hep C, so there's a large bit of our population that's now determining that they have this disease and have to take these specialty medications. Increase in price. So we see about a 15 to 20% increase in price year over year. Huge, huge. And then the pipeline of the expensive new drugs. So the pipeline of drugs, and the pipeline is drugs that are in the study format. So there's phase 1 through 4 trials, generally phase 1 through 3, 4 is after they're to the market. So phase 1 through 3 drugs, there's about 600 drugs. Nearly half of those are in the oncology space. So a number of drugs that will be coming out in the cancer space. If we look at the overall spend for specialty drugs as it relates to total health care costs, you can see down here below, the total health care cost is about $310 per member per month. If we look, the little grid here, so this blue part is the overall health care cost. This is the non-specialty cost, so this is the area now, so this will actually shrink as we get to 2018. Either this will shrink or this part here will expand. So you're seeing roughly $20 per member per month that's spent on specialty medication. So how do we control costs for these specialty medications? So for the drug manufacturers in the room, these are generally the things that you don't want to see. But as a PBM, and looking at controlling costs and making sure that the most appropriate members are on these drugs, we have to put in place quantity limits. So quantity limits is a big thing for specialty drugs. And when it comes to specialty drugs, and we did talk about 90-day supplies, but for specialty drugs, we look at limiting patients, especially brand new patients, to therapy. So if I'm newly diagnosed with multiple sclerosis, I might only dispense a 28-day supply to that patient so we can see how they're doing on that therapy. We don't want to give a 90-day supply if they're only going to take a couple weeks, they don't do well on the therapy, then the rest of that drug goes to waste. So because these are high costs, we try to limit those days in therapy, and then it also gives a chance for the pharmacy to follow up with those patients to see how they're doing on the drug and are they adherent. So we talked about a few cases again in the past where they kept on getting their fills, were they actually adherent? When we have these follow-ups with the patients every 28 days, we ask them, how much medication do you have on hand? So if they say, well, I still have 10 pills or 12 pills, we know that they're not taking their medication, and something that we can address with them or address with their physician. But quantity limits is where we're limiting the frequency of drug that they are getting, so that's extremely important. Step therapy is where we're encouraging members to use a more clinically effective or lower net cost drug before a more expensive or a second-line drug will be covered. So this is when you go to the pharmacy and they say, sorry, you have to take this drug rather than this drug. For specialty drugs, that's the case. We're able to do that not in all disease states, but certainly in disease states such as multiple sclerosis and in rheumatoid arthritis. We have that in place. And then lastly is the prior authorization. So just ensuring that, one, the member is appropriate to get the drug. You would think with these specialty medications, and before I was in this industry about 8 years ago, working at the specialty pharmacy, I would think that all of these patients that are on these high cost drugs, they have horrible side effects. They have to be appropriate for these drugs. Why would a physician prescribe them anyway? And the fact of the matter is, for specific disease states and for specific drugs, there can be a denial rate of up to 50% because the physician is using it inappropriately, or the member is just asking for a drug that they don't necessarily need. So if I'm a member and I'm working with the health planner, if I'm working with the PBM that do not have these mechanisms in place, I could be taking a drug that's not necessarily effective for me and spending a ton of money and putting that money out of pocket, and I'm not reaching a better outcome because of that. So these programs we feel are absolutely necessary when it comes to specialty medication. I'm going to go and talk about a couple different studies that we've done at Prime Therapeutics. So this one is looking at really touching on adherence. And this is a study that we did on a drug called Synagis. And Synagis is a drug that's used for neonates. So there's a high use of Synagis in the Medicaid population. It's for babies that are born generally at 31 weeks and below. And the patients have to get this drug. They generally get their first dose in the hospital when they're in the neonatal unit, and then they're discharged, and they have to continue to get the medication. And they need to get generally between 3 and 6 doses of the medication for it to be effective. RSV, respiratory syncytial virus, it is a virus, so if they don't get this, they could actually get the virus itself. And the cost then of readmission into the hospital is extremely expensive for these babies. So Synagis is also one of those limited distribution drugs where the drug company limits the number of pharmacies that can dispense this drug. And it's extremely important for us to follow up and make sure that the patient is adherent to their medication and then they're getting their fills. So a lot of coordination in that regard. This drug is also a weight-based drug. So you can imagine from a baby's perspective, the weight changes. So then you're going to change and alter that dose. So if we're not doing that, we might be sending a lower dose and what's not appropriate. But if we just are not asking the weight and then just assuming that the baby gained maybe 2 or 3 pounds, that could be extra additional cost. So from a specialty pharmacy perspective, extremely important in following up with these patients and getting this information. You can see that at the top there that for the Synagis, that appropriate drug use reduces hospitalization rates by about 50%. So extreme savings there. The solution is proactive doctor outreach. This is a drug that you generally have prior authorization around because of the expense, $4,000 to $5,000 times roughly 5 injections that they'll have to get. Family education so that they understand the importance of these babies getting this medication. And then simplified drug shipment, making sure that it either goes to the baby's home and or the physician office to ensure that they'll get that injection, and making sure as well that it aligns when that baby or that mother or father is taking that child to the doctor's office. Because if they go to the doctor's office, the medication's not there, then they have another visit. And so then they might not be compliant to their medication. So we talked a little bit about adherence and copay structure in the last session. And we have done some studies around copay structure in working with our plans to understand what is the copay that you can expect to get out of a patient, but still keep them adherent to their medication. And what we had found, and you can see on the graph below here, is that when their copay reaches above that $150 mark, this is now for a 28-day supply, they start not getting their medication. So that's huge. When their coinsurance or their copay, so talking about specialty drugs, which are generally on a 3rd tier or 4th tier when we talked about the differential tiers, when they get that high, they're not going to take their medication. If they don't take their medication, they're probably going to have a lot more spend on the medical side for emergency department visits, physician visits, and cost a lot more. So we really work with the health plans in making sure that they keep this at the right rate for specialty drugs and also employer groups as well. So just a little bit more on the tiering. When we're working with the health plans and employer groups, this is what we recommend. So your generics, your preferred brands, $5 to $10, $40. Your non-preferred brand, preferred specialty between $75 and $100, and then non-preferred specialty at a 50% coinsurance. So it depends on how aggressive the plan or the employer group wants to manage to that preferred product. Another key thing when we talk about specialty patients is being able to have and work with pharmacies in your network that have the ability to administer patient assistance programs. So some of you have probably heard about copay cards, patient assistance programs that either the drug manufacturers support or there's agencies that support these patient assistance programs. They're not eligible within the Medicare space, so this is generally for our commercial membership. But we had found that patients that are on the patient assistance program certainly help out when they have a high cost copay. So the average cost of a brand specialty claim was around $2,200. Member copay was around 5.9% or $135. We know that there's an impact to adherence there. And so what we do is with Prime Specialty Pharmacy or what Prime Therapeutics owns, we have a dedicated department to ensure that patients are being presented ideas around the patient assistance programs where the need is. So if they present, well, I'm not able to get my medication because I cannot afford that copay, we will refer them to this department so they can work either with the drug manufacturer copay card or with an agency that has the ability to administer this. So the average member savings was $347 when we were using a copay card. So extremely important in having this ability. And so as I get to the end of the presentation around specialty drugs, and just wanting to propose in conclusion, Prime Therapeutics has a purpose that we want to help people get the medication they need to feel better and live well. Specialty medicine is getting more and more expensive, so we need to manage to those certain protocols on appropriate use, ensuring that plans, health plans are putting in place quantity limits, step therapy, prior authorization. Let's try and work together to keep medication affordable. And then right at the bottom, is there a way to get drug costs more affordable and more available at less cost? So from a legislative perspective, as we talk about biosimilars, that's going to be extremely important for specialty drugs. We want to make sure that we advocate for biosimilars because that will ultimately overall lower cost. And if you think about this in the traditional sense, so when traditional drugs are coming out and then there's a generic available, so much lower cost when that generic is available. It looks like biosimilars will come in at about a 30% reduction from what the brand is. So there's always going to be clinical utility. There even is in traditional drugs to utilize that brand, but we want to make sure that we push forward and make sure that biosimilars will be available in the future. And with that, I think we'll go to questions. Thank you so much.